Hello everyone, in this video we are going to take a look at ectopic pregnancy. So let's look at the definition first. So it is ectopic pregnancy is one in which the fertilized ovum is implanted and develops outside the normal endometrial cavity. The most common site of ectopic pregnancy is the fallopian tubes. So outside the endometrial cavity, which means it is ectopic. Coming to sites, so tubal is the most common, and then ovarian, then abdominal, then the uterine. So under tubal we have the most common sites: ampulla, isthmus, infundibulum and interstitial. Ampulla, isthmus, infundibulum and interstitial. Let's look at a diagram to see parts of fallopian tube. So here you can see this one is better. So there is ampulla, isthmus, infundibulum and interstitium. Yes, this one is the better one. So ampulla, isthmus, infundibulum, interstitium. Then comes the ovarian and abdominal, uterine, where cervical is the most common, like non-specific, cervical, angular, cornual, or if there is a caesarean scar. Now taking a look at etiology and risk factors. So first one, salpingitis and PID increases the risk 6 to 10 fold due to ciliary loss, tubal luminal narrowing and adhesions. 6 to 10 fold due to ciliary loss, tubal narrowing and adhesions. Coming to iatrogenic causes, contraception failure, tubal surgery, ART procedures. So first one, IUD use increases the risk of tubal pregnancy by 7 times, and tubal surgery also increases the risk, reconstructive one, and ART procedures like IVF and ovulation induction increases ectopic risk. Coming to other risk factors, previous ectopic pregnancy, infertility, tubal endometriosis, prior abortion. So all these things are the causes and risk factors of ectopic pregnancies. Coming to clinical features, so we have two major classifications over here: acute ectopic and unruptured tubal ectopic. So acute ectopic, so there are symptoms and signs. So symptoms include abdominal pain, amenorrhea, vaginal bleeding, shoulder tip pain, vomiting, fainting attacks. So amenorrhea, abdominal pain, amenorrhea, vaginal bleeding, shoulder tip pain, vomiting and fainting attacks. Next, coming to the signs: pallor, features of shock, abdominal tenderness, pelvic examination reveals tenderness on cervical motion, and uterus may float. So let's take a look the explanation for signs. Why these signs for ectopic? Just to be clear, so internal bleeding, peritoneal irritation and hemodynamic instability. So pallor and features of shock could be secondary to these things, like these are also seen in this particular case. That's what. So there is a bleeding and abdominal tenderness because of irritation of peritoneum, and then there is cervical motion tenderness, blood accumulates in pouch of Douglas, irritating peritoneum, movement of cervix, stretches peritoneal structures, worsening pain, and uterus may float. Hemoperitoneum pushes the uterus upwards, making it feel mobile or floating. So these things, and also shoulder tip pain, most likely due to the irritation of peritoneum itself, but just let's referred pain due to diaphragmatic irritation from hemoperitoneum. The pharyngeal nerve supplies both diaphragm and shoulder tip. So next, coming to unruptured tubal pregnancy, high suspicion in sexually active females with abnormal bleeding or pain. So that is one. And symptoms and signs. So symptoms: delayed periods, spotting, continuous flank pain. delayed periods, spotting, continuous flank pain. And signs include soft uterus, pulsatile tender mass in adnexa. So let's just copy this entirely and just take a look as to why we have specific differences in these. Why the differences in these? So acute ectopic, so due to peritoneal irritation and all that, so blood is already present, so that is the main one here. But in case of unruptured, abnormal, it's an abnormal pregnancy and inadequate HCG is produced, and then there is like impending rupture, not completely ruptured. And then in case of specifically the soft uterus is still adapting, but it's an abnormal pregnancy, right? And pulsatile tender, this one is because the growing ectopic pregnancy on the fallopian tube can be felt on examination before the rupture. So these are the things. So maybe it's a good idea if I create a Google Doc. So and I will just copy this there, and maybe I can share it later on. Yes, I'll just mention it here, ectopic. I'll just put it in the description, yeah, so that it's easier for you guys. Yeah, next coming to the diagnosis. So investigations and treatment. So investigations, we have blood tests, hemoglobin, ABO-RH grouping, WBC count, and culdocentesis, aspiration of non-clotting blood, and then there is beta HCG estimation. So culdocentesis, better would be with the diagrams wherein from this you are taking out blood from the sac, so pouch of Douglas. So here there is rectum and there is uterus, and here the blood is getting accumulated. So whatever is getting accumulated, you aspirate it. So that is culdocentesis. Beta HCG estimation. So as we know, if there is abnormal pregnancy, it is the rate of increase is not that high. Yeah, that is the key. Beta HCG is not that high. So positive in 95% of the ectopics. Just make it clear. Beta HCG estimation in ectopic, more or less. It is typically lower and rise abnormally slowly. So that is what, just to be clear. Yeah. Then coming to transvaginal transvaginal sonography, detects empty uterine cavity with adnexal mass, and laparoscopy, confirmatory and therapeutic, because you can also handle it with laparoscopy. So again, blood tests, hemoglobin, blood grouping, and WBC count, just to see what the current status is with respect to anemia, with respect to immune, the infection and all that, this peritoneal irritation and all that, right? Then coming to culdocentesis, aspiration of the blood, and then beta HCG estimation. So you do ELISA, and then for transvaginal sonography, we need to we can see empty uterine cavity, and then laparoscopy, confirmatory and therapeutic. Then coming to treatment, acute ectopic, chronic ectopic, unruptured tubal ectopic. So acute ectopic, principle is resuscitation and laparotomy. Anti-shock treatment includes Ringer's solution, blood transfusion, and laparotomy includes hemodynamically unstable patient or laparoscopic contraindications. So laparotomy is different from scopy. So again, principle for this one is resuscitation and laparotomy, that is the key one, and what we use is Ringer's solution and blood transfusion, and laparotomy is done in case hemodynamically unstable or laparoscopic contraindication. Coming to chronic ectopic, managed by laparotomy, identification and removal of ectopic mass. And in case of, so these are the this one, acute and chronic ectopic pregnancy. Then coming to unruptured ectopic pregnancy, so that is pulsatile mass and all that. So medical management, methotrexate 50 milligrams per meter square IM, this we learned previously too for MTPs. Monitor beta HCG levels. Then coming to conservative surgery, laparoscopic or microsurgical laparotomy, and then linear salpingotomy, segmental dissection, femoral expression, or salpingectomy. So these are the names which you need to remember. Let's look at, do we need to, yes, better to look at the meanings of all of these. Yeah, meaning. So typical this one. So longitudinal incision made on the fallopian tube over the ectopic site. Yeah, so this in case of tubal. Yeah, unruptured ectopic pregnancy ampulla, fertility preservation. Segmented resection, section of the fallopian tube containing ectopic pregnancy is removed and remaining ends may be sutured or left open. Then coming to fimbrial expression, milking technique, the ectopic pregnancy is squeezed out through the fimbrial end of the tube without making incision. So you squeeze it. Then coming to salpingectomy, entire fallopian tube is removed along with the ectopic. So then expectant management, observation in case with low beta HCG levels and no symptoms. Coming to prognosis, early diagnosis and management have significantly reduced the mortality, chances of recurrence 1 in 10. Subsequent intrauterine pregnancies are 60 to 70% with conservative surgery. So better do it. Next, coming to prevention, early detection through high resolution TVS in suspected cases and proper management of risk factors like PID and careful use of ART procedures. So this was an overview. It is definitely, you need to expand more on it because it can come as a 10 marker, but still it is a good enough notes for key points. All right, okay, then bye bye.